can get started.
Great. Thank you very much, Allison. Okay, so today I'm going to be talking about the role of the Oncology Drug Access Navigator. And because I'm located in Ontario, the information is mostly focused on Ontario, but there are drug access navigators located in most of the other provinces. So I'm going to go over that as well. There we go. Oh, there's a little bit of a lag getting the slide. So, okay, so the agenda today is why do we have drug access navigators? I'm going to talk about our organization in Ontario called ODANO, and a case study of how we actually help patients, what this really looks like from the first-hand experience. A little bit about National Pharmacare and how that may impact drug access in Canada, as well as the wish list that we have. So a lot of our goals and our wish list really lines up with what patients experience. So what helps us helps patients at the same time. So why do we have drug access navigators? So the first Oncology Drug Access Navigator started in Ontario in 2007. So it's been a little over 10 years now. And the role began to help with the complexities in drug reimbursement in oncology clinics. So while IV therapies in Ontario are covered through Cancer Care Ontario, other drugs are funded through the Ontario Drug Benefit, or ODB. So this is similar for the eastern provinces from east of Manitoba. In the western provinces, it's more of a unified funding model where the IVs and the orals are funded together, but there's still drug access navigators located in those provinces. So as experts in oncology drug access, we're able to help connect patients with the treatments prescribed by their physician. So typically, a physician may come to us, an oncologist or a hematologist, and they may say, I'm seeing a patient shortly, they're this many years old, and I want to get them this particular drug. What can we do? And then from our knowledge base, we can advise those physicians what is available for that patient. So typically, depending on the age of the patient and what's available to them, it may be through public insurance. So in Ontario, that would be through Cancer Care Ontario or through the Ontario Drug Benefit. A lot of patients also have a private insurance plan, so they may have their own private insurance through Great West Life or Manulife or Sun Life, something like that. We also tap into pharmaceutical patient support programs, and they will sometimes provide compassionate drug, and sometimes it's a mix of all of the above. So we have situations where a patient may get one drug through public insurance, another drug through private insurance that's not a public benefit, and they may be on another drug that's through a pharmaceutical company drug program. So you can be on all three. You can be on two public drugs and one private, a whole array, as we get more and more complex regimens in oncology. So most drugs are typically funded through the government, through the public plans in different provinces, but a lot of the newer drugs are through these patient support programs or also through the Health Canada Special Access Program. So what will end up happening is a drug is approved by Health Canada, but there's usually a gap of a year, 2 years, or sometimes longer between Health Canada approval and the drug going onto the public formulary in the various provinces. So in that interim gap, patients will usually be only able to access the drug through a pharmaceutical patient support program, or also if they have an insurance plan of their own, they may be able to get it through that mechanism. But it really depends on the insurance plan. It depends on the drug and the pharmaceutical company. We also use this Health Canada Special Access Program, or SAP, and that's for drugs that are approved in other countries outside of Canada. So they haven't gotten Health Canada approval yet. But for instance, maybe they've been approved in Europe by in England, or they may be approved by the United States. And this is another mechanism that we can use to access drugs, and typically they'll have no charge to the patient. But because they're through Health Canada, there is more paperwork involved. It's not usually as clear-cut as getting something that's funded by the province, for example. So the physicians can come to us and we can advise them that's going to be a drug that's through the SAP program, or this is a drug that's not funded by the province yet. You're going to have to go through the patient support program to get this medication, or this drug is only accessible through whatever various mechanism that we can tap into. So our roles across Canada, we do have drug access navigators, obviously in Ontario. There's at least about 60 to 70 of us across the province. Every cancer center in the province pretty much has at least one, sometimes more, depending on the size of the center. There's also drug access navigators in British Columbia, Alberta, Quebec, and the Atlantic provinces also have this role. So in the different provinces, everyone's role is a little bit different because of the public funding models. For example, you may have more access in BC for particular medications, or you may have more access in Ontario for different medications. So when it comes to the public payer, the role does vary a little bit, but when it comes to the pharmaceutical patient support programs, they're typically the same across the country. And similar for insurance providers, a lot of the plans are the same across the country. So you may use insurance more often in Ontario, but you will still have people with insurance plans in Alberta or in BC, and they'll still have a drug access navigator available there to help them. So the ideal model for a healthcare team in the oncology clinic is everyone is there to support the patient, of course. That's our primary goal. And the typical team is a lot of people may think of immediately the physician and the nurse, but there's also the pharmacist. There's also the social worker there to help patients, and there's also the drug access navigator. So we all have our expertise and things that we can focus on especially well to help the patient, but we also help each other. So we work as a combined team to support the patient. So in Ontario, because we have several dozen drug access navigators, we formed a group. So it's an informal group of all of us together where we can help each other, called the Oncology Drug Access Navigators of Ontario. So it's because pretty much every oncology clinic in the province has one or more drug access navigators. This is a way that we can support each other. So if you're in Ottawa, for example, and a patient comes into your clinic, and the physician's requesting a drug that you have very little experience with, you can reach out to other people in the network, and then somebody who has more experience with that drug can help out. So for example, if there's a particular form needed for a drug or a situation that someone's not familiar with, like I said, you can always reach out, and someone else in the province can likely have experienced that situation. They can send you the form they used, or they can provide you an example of what they did to get that medication. And then when you need help, someone else will reach out to you and support you when needed. So it's typically used for sharing files, like I said, for enrollment forms or forms for insurance, forms to the government, various things like that. And we basically just support each other in that way. And we also have a new website that's launched just in September. So that's at ODANO.ca. We have a lot of information there for patients on public coverage, private coverage. It's focused mostly on Ontario, but there is information, like I said, that is universal across the country when it comes to things like calling your insurance plan. That's something that would be relevant anywhere in the country. So I do recommend, if you have a chance, to go to the ODANO website and see, there's relevant information there if you're newly diagnosed with cancer, or if you know somebody who may need help, or you just want to learn more about the reimbursement world in oncology. It has lots of great information. So a really common question that's been coming up is how to find your drug access navigator. So typically in a center, the physician who is prescribing the medication will refer that person to the drug access navigator to see if their private insurance will cover the drug, or to get them to fill out specific forms, for example, to a patient support program, things like that, or prior authorization for someone's insurance. But sometimes they are missed. And if a patient is not referred to a drug access navigator, but is paying out of pocket for their medication, perhaps they have a copay that's quite expensive, or they're paying for their cancer drug full price out of pocket, it is very important to try to reach out to a drug access navigator, because there may be a program that's there somewhere that can cover the cost of the drug, or at least your copay, or reduce the financial burden of your medication. So if you haven't been referred to one, you can always ask your physician. And if you're in Ontario, there's a very good chance that your center will have one or more drug access navigators that can speak with you over the phone or meet with you in the clinic, and they can connect you with a program if there is one available for that drug. But also on our new website, we have a Contact Us section where you can say the center where you're at. This is Ontario specific, but if you are in Ontario, you can choose the closest center to where you're being treated, and then that message that you send in to us will be routed to your local drug access navigator. So this is a way that you can reach out to the person who is most applicable to your area. If none of these actually match, like any of the centers are not close, you can just choose not applicable. But somebody from ODANO will reach out to you, and we'll do our best to make sure that we connect you with any applicable programs. And if there isn't anything, we'll let you know. There's no program for that particular drug. But if there is any programs, we can make sure that we can connect with your physician and get any sort of form signed and try our best to make sure that you're not paying anything that you don't need to pay out of pocket. So in Ontario, the reimbursement model is split into two methods. There's Cancer Care Ontario, which is the governing body for IV therapies and cancer care in general. So they do cover the IV therapies that are provided in the hospital. And then there's the Ontario Drug Benefit, which covers orals and injections. So in oncology, we're seeing more and more oral therapies coming out because they're better and easier to take than coming necessarily to the clinic every month or every few weeks for an IV therapy. But because the funding model was put in place quite a while ago when the majority of cancer drugs were just through IV, it is becoming a little bit more problematic in Ontario because the IV therapies are still completely covered through Cancer Care Ontario, where if you are getting an oral version even of the same drug or an injection for your cancer, it's not as clear-cut. If you're over 65, you automatically will have Ontario drug benefits. But if you're under 65, it becomes a little bit more complicated, and you'd have to apply to the Trillium drug program for that. So I'll go over that in just a minute. So over 65 in Ontario, automatic ODB benefits. So on the first of the following month, you're covered by ODB. If you're under 25 currently in Ontario, you also have ODB coverage. But those between 25 and 65 have to jump through a little bit of an extra hoop, so they'll have to apply to something called the Trillium drug program. And anyone can apply for Trillium. There's no qualifications for that. The only barrier is the deductible. So there is a 4% of net household income deductible for Trillium. So if you're between 25 and 65, there will be that 4% deductible applied when you get approval from Trillium. So as long as the cost of your drugs are over that, then Trillium is definitely going to be beneficial. And you can kind of calculate from your tax returns to see what 4% of the net household income is. So that's after tax. And all you need is your OHIP to apply for Trillium. As long as you have that, you can be approved for Trillium. It doesn't necessarily mean it's going to be useful for you, though. So it is something that you can always apply. There's no proactive charge or anything like that. It's not like a private insurance plan where they'll charge you a premium. You'd only pay when you buy drugs. So if you have a deductible of $1,000 for the year and your drug costs are only $250, then it's probably not going to be very useful to apply, but you still could. It's just that Trillium wouldn't end up covering any of the costs of your drugs, really. But if your drugs cost $8,000 a month, which is a reality in oncology, then your $1,000 deductible is definitely something that it's still high, but it's something that would prove a lot of benefit by applying. So again, Trillium will only cover drugs that are funded through the province through the Ontario Drug Benefit, but it doesn't hurt to apply. You can always apply and just have it sit there and not really do anything. But it would be there as a sort of a backup if there is something new prescribed in the future and you needed to apply down the road. At least you've already applied. So for private drug coverage, about 30% of Canadians have their drugs covered through a private insurance plan. So again, these are through companies like Great-West Life, Manulife, things like that. But when it comes to cancer drugs, because of the price of these medications, they will almost always require prior authorization. This is something that the Drug Access Navigator will assist with. These are forms that they're kind of like applying for, like to the Exceptional Access Program, which is to request specialty drugs from the Ontario Drug Benefit. The insurance wants to know exactly why you're using this drug, and if they deem that it meets criteria that are internal at their end, then they'll approve that drug. So it's usually a couple of pages long, has to be signed by the patient, has to be signed by the physician, but we will send those into the insurance company for you, follow up, get them expedited, and try to get it done as quickly as possible. It usually takes at least a few days minimum, but then once it's been approved, then you can go to the pharmacy to buy your drug with your private insurance. If it's rejected, it may be because of the criteria are not met, but we can also appeal from here at the hospital. So that's another thing that we can do if the insurance says it's rejected for a specific reason. Depending on what that reason is, we can file an appeal for you, and then have them take a second look at the request and see if we can get that medication for you. But even if the drug is approved, there are some additional barriers that can come up. So private insurance plans often have annual financial caps, copays, and deductibles. So when it comes to financial caps, these are a lot of the plans that we see are caps of $10,000, $25,000 per year. And outside of oncology, that actually does go quite a long ways. If you're just getting the occasional antibiotic or something like that, or you're on Crestor or something, $10,000, $25,000 per year goes quite a ways. But when it comes to the oncology space, that can be just a single month of drug. So we do find that oncology, these caps, which we consider to be quite low, can be reached fairly quickly. So when we have somebody go through their private insurance plan, say for 1 or 2 months before the drug plan is exhausted, we have to make sure that either the drug is also a public benefit that person can apply to Trillium, or that we can get the rest of the year covered through the drug manufacturer. So that's where we might enroll with the patient support program as well. And depending on the program, they may say, as long as the drug is covered by the insurance for a certain amount of time, we can provide free drug for the rest of the year. But it is on a case-by-case basis, and it varies from manufacturer to manufacturer. When it comes to deductibles and copays, we also use those patient support programs through the manufacturers, because they will often, in oncology, provide financial assistance. So the typical for an insurance plan is about 80% coverage, and the average for the patient support programs is 20% of copay assistance. So if you have a Sun Life drug plan that covers your breast cancer oral therapy at 80%, very often the manufacturer will have a patient support program that will offer 20% copay assistance. So you're not out that 20%. So I have a case study of just kind of how this all plays together. And this is a bit of a complicated example, but it is something that definitely does happen. And it sort of shows all the examples of private, public, everything combined. So this is an example of a relapsing 62-year-old patient with multiple myeloma. The patient's already had chemotherapy called Cyborg-D, and they've also had a stem cell transplant. And this patient has a private insurance plan. Her hematologist would like to use a drug called Darzalex, or daratumumab, in combination with a drug called Revlimid, or lenalidomide, and dexamethasone. So these are two drugs, the Darzalex and the Revlimid, made by two different manufacturers. The Darzalex is an IV therapy, and the Revlimid is an oral therapy. So based on PCODER's report, this is the governing body that evaluates new drugs to Canada to see their cost effectiveness and how useful they'll be. This combination costs about $6,697 per month for the Darzalex and $8,904 for the Revlimid. And then the dexamethasone is $12. So this comes to about $15,000 per month. So the first few doses of Darzalex cost more, but after it reaches its maintenance dose, that's about $15,000 a month for these three drugs. So this is a very real-world example, happens in our clinics to patients who are in this same situation with multiple myeloma. So the physician will make a referral to the Drug Access Navigator how to get this covered. So the Drug Navigator will research her private insurance plan, and her drugs, the Revlimid and the Darzalex, are covered at 80%, very typical. This plan has no financial cap per year. So this is very good news. If a drug is $15,000 a month, and we find that this person has a cap of $5,000, $10,000, even $50,000, it's not going to be enough to cover a full year of drug. That makes it much more complicated. If the drug manufacturers don't have any mechanism to cover the rest of the year with free drug, that would mean it's an immediate halt to this therapy. But because this plan has no financial cap, which is a very great thing to hear, it means that at least we can probably get all these drugs covered for at least 1 year at a time. And due to the price of these drugs, the insurance requires prior approval. And according to the insurance, privately paid IV therapies cannot be given in the hospital. This is another thing that we commonly see. IV therapies that are given in a hospital are, according to the insurance providers, should be funded by the hospital. It makes sense to them. So in this case, if it's going to be privately paid, it will not be given in the hospital. So this patient would have to get their Darzalex at a private infusion clinic, and then the Revlimid, being an oral therapy, would be taken at home. So what can be done in this situation? So the Drug Access Navigator, knowing that prior authorization is needed for the Revlimid and the Darzalex, will submit the prior authorization forms to her insurance with clinical references and a physician letter for the insurance to review. So they'll take their time deciding if this patient meets the criteria according to her insurance plan, and that they can get their Darzalex and Revlimid covered. We'll also enroll her with the manufacturer's patient support programs. So because these are two drugs made by two different manufacturers, there will be two different patient support programs. There will be the Darzalex program and one for Revlimid. And these programs will provide 20% copay assistance for this patient. And for the Darzalex, they'll coordinate the private infusion of the Darzalex through a private clinic. So again, this is why we heavily rely on these patient support programs. It's for the financial assistance, but also for situations, for example, with a privately infused drug. They will help coordinate that. If we didn't get financial assistance, this 20% copay for these drugs, 20% of $15,000 is going to be very cost prohibitive to this patient on a monthly basis. So there are situations where somebody would be able to afford this, or if it was 20% of a much lower number, it may be affordable. But if it wasn't for these copay assistance programs, very often patients just wouldn't be able to get their medication. So in addition, we'll enroll her with the Trillium drug program for the Revlimid copay assistance, and we'll arrange to have her application expedited. So when it comes to Trillium, we'll assist patients with applying. It's sometimes done by a social worker, but depending on the hospital, it may be done by the Drug Access Navigator. We can also contact Trillium to make sure that they know that this is a request for a cancer patient and to have it expedited as quick as possible. So the outcome of all of this paperwork and coordination is after 9 days, her insurance has approved her prior authorization request for Darzalex and Revlimid. She's scheduled to start on her new treatment shortly after that. So once we have approval, we have to find a chair that's available for this infusion to take place in. So typically those are booked, but once we have a chair available, she can go to that clinic and get everything set up. So between Trillium, the patient support programs, and her insurance, total funding has been secured for all of her prescribed medications. So this patient is going to get a drug or several drugs, comes to a little over $15,000 per month, and everything will be covered between the various programs, her insurance, and she won't end up paying very much out of pocket. She may pay like a copay, something like that, a few dollars, but pretty much everything will be covered. So I also want to talk about National Pharmacare, which is the hot topic right now. Dr. Eric Hoskins, the former Ontario Health Minister, is the one who's working with his implementation committee to have this rolled out. So in the spring of 2019, there will be a recommendation made to Parliament to see what this will look like. And it's still up in the air as to what sort of style of National Pharmacare may be recommended to Parliament. But the role of the Drug Access Navigator, depending on how it rolls out, there will very likely still be a need for Drug Access Navigators, but the role may change. So I want to explain a little bit how that might happen. So depending on what model is chosen, private insurance may still remain after National Pharmacare if it was to roll out. So Drug Access Navigators would still be able to help with the prior authorization forms, copay assistance programs, a lot of like what we saw with this multiple myeloma patient. So depending on the drug, if it's a public benefit or not under the new National Pharmacare, if there would still be drugs that would be covered strictly through private insurance, very likely, depending on the size of the public formulary. So it still would remain that Drug Access Navigators would assist with forms, patient assistance programs, things like that. And depending on the formulary used, in Ontario, for example, we have the Exceptional Access Program, where we would fill out requests similar to prior authorization forms to insurance, but they would go to the Ontario government. And depending on the criteria, if it's met for a patient, they would cover a patient's drug. So this is very common for a lot of the specialty, more expensive drugs in Ontario. And even if we have a national formulary where all the provinces abide by a particular formulary, typically if there's going to be expensive drugs, which is the realm of oncology, they would still need special authorization of some sort. like the Exceptional Access Program, and that would still be something that the Drug Access Navigators would handle. So as I mentioned earlier as well, there's a time delay between Health Canada approvals and public drug funding. So the gap for cancer drugs is typically filled by those patient support programs. So with a national formulary, National Pharmacare of some sort, it's very unlikely that as soon as Health Canada approves a drug that's going to be added to the formulary, there's very likely to still be some sort of lag in between. So that's another place where private insurance would be able to kick in to pay for drugs. And in oncology, we're always trying to use the newest therapy, whatever is the newest and works better than the older drugs. So there would still be a demand for these newer therapies. And that would be something that would be through the patient support programs as well. They typically have programs for a year or two until the public payer starts to pay for medications. And that's something that we would coordinate with patients and the physicians to still do. And also the special access program from before. So drugs that are not Health Canada approved, if we're going to request a new medication that has been approved in the United States by the FDA or through somewhere in Europe, we would still go to the special access program to request those medications. That's still something that the Drug Access Navigator would be doing. So I have a little bit of a sort of wish list, what we see as frontline healthcare workers working in a hospital with patients every day. And these are things that if we could get, they would also help patients. They would help the flow of the clinic. They would help physicians. These would help everybody. So how can we make things better for us and patients? So a lot of our systems in healthcare, and I'm sure everyone's very aware of this, is that everything is very paper-based still. We need more electronic systems. Prior authorizations are still typically faxed in. Requests to the Exceptional Access Program are still faxed in. They're still paper-based, lots and lots of paper. The Trillium application forms in Ontario are still paper-based. It'd be great if we had some sort of online mechanism, electronic EAPs, electronic insurance prior authorizations to allow processing quicker and cut down on the stacks of paper that we have. Paper can go missing. It gets degraded over time with faxing. There's a lot of benefits to having these things done electronically, and hopefully that'll be coming along at some point. Another issue is the wait times for these medications. So cancer is urgent. It's something that everyone in my clinic and every clinic that I can think of would agree on. We need to get patients on drug as soon as possible. As soon as it's prescribed, we want patients to be able to walk away with their drug. That's my goal. Anything that we can do to eliminate any time and waste is what we want. So improved wait times for prior authorizations to insurance. We want to have them done as quickly as possible. It can take right now for insurance into the government 2 weeks, sometimes even more if you have to appeal to get a decision. And even if after the decision, there's still more that goes on. And if it's a negative decision, it can take even longer. So if you're waiting 2 weeks to hear a no, all that time, you're not able to really do anything, and it causes a lot of anxiety for everyone involved. So in our perspective, it should be about 3 business days at most, and that's to private insurance as well as the government. And with the Exceptional Access Program, their target for oncology drugs is 3 business days. And it does happen sometimes, but very often it's well beyond 3 business days. And we end up relying on patient support programs for a bridging drug, where they'll provide a week or 2 or a month of drug while we wait for the government to make their decision on the medication. It should be done much quicker. So another component of healthcare, and this is not just specific to drug access and oncology, but bringing down silos. So as we move towards combination therapies in cancer, drugs are becoming more common from different sources. So like I said in the beginning, we have IV therapy given with oral treatments. We have IV therapies that are from 2 different companies. And we find that there's a lot of confusion for patients, a lot of confusion for physicians, drug access navigators, when a drug has to come from one patient support program, one other drug comes from private insurance, another drug comes to the public payer, and it can be very complicated to navigate all of this, and it's all just for one regimen. To have more coordination between the government, between from drug companies. If you're making an IV therapy that is given with another IV therapy from a different manufacturer, to make sure you work with them to make sure that the rollout of your medication is smooth. So it's because a lot of these players don't necessarily communicate with each other. It can cause a lot of harm to patients and a burden to coordinate. We often will find that if a patient has to be enrolled with 3 different patient support programs to get 3 different drugs that are given together, they're going to get 3 phone calls from each program multiple times. And a very common complaint is that you can have a dozen phone calls very easily when you're coordinating between your pharmacy, 3 different pharmacies potentially, 3 different patient support programs, and it can just become overwhelming to somebody who's been newly diagnosed with cancer. So any way that that can be streamlined, bringing down these barriers and silos would be a great advantage to everybody. So I did mention our website, ODANO.ca. I do recommend that if you have time to check that out. If you're trying to find a drug access navigator in Ontario, you can use our Contact Us on our website. We also have a Twitter and Facebook page at ODANO Canada. So if you want to follow us on there, I'd recommend that. And we do want to be in touch with as many different patient groups. Anyone who's interested in hearing more about this or has questions about this or knows someone who could benefit from a drug access navigator, these are the best ways to reach out to us. And then we can do our best to make sure that we help you as best as possible. So thank you very much. And I'll turn it over to you, Allison.
Yeah, perfect. Thanks so much, Alan. That was a fantastic presentation. We have a couple of questions coming in right now. So just a quick reminder to everyone, now's the time. If you have any questions for Alan, just type them in the questions panel that should be on the right side of your screen in the GoToWebinar panel. So the first one here was in reference to the case study about multiple myeloma that you mentioned earlier. And the question was, why would CCO not cover the cost of the drug?
So currently, Darzalex specifically is a very new therapy, and it's one of those drugs that's in that gap between Health Canada approving the drug and the public payer paying for it. So Health Canada has already approved the drug. It's safe. It's gone through the normal processes for drug review, and we're just waiting right now for this drug to be picked up by Cancer Care Ontario. There's new drugs added all the time, but this is one of those drugs that's in that interim gap. So we are expecting that at some point, hopefully in the near future, that Darzalex will be funded by CCO, but we're not at that point. So if somebody who needed this particular regimen of Revlimid and Darzalex in May or in August of this year, they would have had to get it through their private insurance plan if they had it. So it does create some inequalities to people who don't have a private insurance plan. But at this time in Ontario, you cannot get it through CCO. And even after it gets funded by CCO, there will be another drug after it and another drug after that. There will always be drugs until the review time is smaller, but there will always be new drugs, at least for the foreseeable future, where Health Canada approves a drug, and there's going to be that 12 to 24 months of gap before it's picked up and paid for by the province. And that's where we're at with Darzalex.
Okay, thank you. There was another sort of follow-up question from when in the presentation you were talking about private infusion clinics. And the question is, what if there's no private infusion clinic where you live?
So I'm based in North York near Toronto. So thankfully, if you're in like a very well-populated area, there's lots of clinics around. But there is a massive disparity, especially in Ontario and in the northern regions. So I haven't personally experienced this, but I know from my colleagues in places like Grey Bruce, there are patients very regularly who travel massive distances to get their drugs. So they may end up driving hours to a private infusion clinic, the closest one available, staying there for the night afterwards in a hotel, and then potentially driving back the next day. It's a massive hardship to patients in these areas. There aren't enough private infusion clinics in sort of the more sparser areas of the province. And then because of some of these rules with private insurance, they won't allow it to be done in the hospital anyways. So it does create quite a lot of problems. So it's not a massive problem for everybody, but the patients who are impacted by this, it's a massive inconvenience for them. It's really not fair to that. There are situations where you can sometimes appeal to the insurance if you're in such a situation. You can explain that this person is going to be driving 5 hours each way to a private infusion clinic to get their drug, and they're a certain age, and it's going to be very burdensome to do that. And potentially the insurance may say, okay, we'll allow it to be done in a hospital, but that's kind of the best option if somebody's in that situation. It really is unfair.
Yeah, for sure. Thank you. So the next question was a gentleman asking, he lives in Alberta and was wondering if he could have a contact for a similar program. Would he contact like ODANO.com and kind of you guys could kind of send them in the right direction? Is that how that would work?
Yeah, so for outside of Ontario, if you do go to ODANO.ca, use our Contact Us, we can connect you with drug access navigators in the other provinces. There are 2 in Alberta. There's 1 in Edmonton and 1 in Calgary. So we can definitely, pass along your email or anything to those people, and then somebody from closer to you can reach out and help you as best as possible.
Yeah, perfect. Thank you. And that's worth mentioning as well to all the attendees on the line that in the follow-up email tomorrow, we will also be including a link to ODANO, so you guys can contact them directly with any of the questions you have regarding that as well. Sort of a related question. Someone here asked, do you know if there's a similar group as ODANO in any other provinces?
So there isn't a specific group like ODANO, like not as organized, I would say, as we have in Ontario. We've been at the forefront, I guess. We've had drug access navigators in Ontario the longest, and there's also the bulk of us are in Ontario. So there are a few, maybe 25, 30 outside of Ontario. So there are a few in Quebec and in BC and things like that. They don't have the same level of structures as we have in Ontario, but that's because their role started far later. Typically, in Ontario, we've had the role for 11 years, whereas you go to BC, it's maybe it's like 4 years old or so. So it's a lot newer, and there's only a few of them. So they don't really have the resources and infrastructure to set up such a formal group like we've been very lucky to have in Ontario. But it is coming along. Just a few years ago, there was only a handful in BC, for example, and now I think there are about 15. So it is growing there, and each of the centers at least the majority of the centers, I think in BC has a drug access navigator now. So potentially, because this is a newish role to Canada, they will have something hopefully in the future, potentially their own website, and their own sort of group where they can help each other and help patients in their local regions better.
Thank you. Yeah, that's good news to hear. Next question here says, do you have any further suggestions for how manufacturer support programs can better work with drug access navigators to allow for a better patient experience?
Sorry, was that the patient support programs?
Yeah.
Or patient groups?
Manufacturer support programs, it says here.
So there's many of them. I would say that the biggest complication is the fact that there's like a program per drug in a lot of cases. Some programs cover multiple drugs, but we find that there's more or less a program per drug, and that's just the way it's been rolled out. So a new drug comes to market and it gets a new program. It would be so much easier for patients as well as drug access navigators to sort of fold them in together. And I know that there's resistance from some of the manufacturers from doing that, especially if there's competitor drugs or something like that. But it would be, it would streamline and keep some of these silos down, like I'd mentioned. If there's 2 drugs that are going to be given together, the reality is that the patient doesn't want to hear from 2 different patient support programs and have their copay assistance come from 2 groups. To the patient, they just need copay assistance for their treatment, period, right? So they don't want to have 15 phone calls. If there's any way that we can have these barriers brought down where it can be a single phone call and have the copay support worked out for their 2 drugs or whatever it is, and have it sort of an all-encompassing program from these patient support programs, that's kind of the better model that I would like to see. Because the reality right now is you probably have maybe 30, 40 different patient support programs. There's many of them, various drugs. Older drugs, sometimes the programs go away if the drug loses its patent and is not as popular, but we constantly have new programs coming along, and they may be through the same provider, like we have companies like Bayshore and McKesson who provide these patient support programs, but they're typically siloed off between each other. So even if Bayshore has 15 patient support programs, they're not connected with each other because they're from different manufacturers. And patients don't really see that. That's kind of just an annoyance. And it's frustrating to us at the hospital to have to go through multiple hoops where we have to fill out, a small stack of paper for 3 drugs as opposed to just having it all sent into the same place. So that's something that we'd like to see sort of improved, hopefully in the long run if possible.
Thank you. Our next question says, there we go. Are there any drug access navigators identified for special populations, such as pediatric patients who may have some unique issues in accessing drugs through existing mechanisms? Or would it be best to contact ODANO with this question directly?
So that's a great question. That's actually another area that this reimbursement sort of position, this DAN position is expanding into is different patient populations. So because of the cost of the drugs in oncology, we've been at the forefront of providing financial assistance programs and things like that for patients. But there are expensive drugs for other populations. So rare disease. There's expensive drugs in a lot of different disease areas, rheumatoid arthritis and multiple sclerosis. There's lots of expensive drugs that need financial assistance and coordination as well, pediatric populations. So that is something that is, I hear, word of mouth that is being looked into from different groups. Perhaps one day there will be a drug access navigator at CAMH helping mental health patients. We may see in a multiple sclerosis clinic drug access navigators, things like that. But we're not at that point yet. It's still pretty much, it's still a fairly new role, right? It's not like physicians and social workers who've been around for decades. It's still in its infancy, really, and it's still really just relegated to oncology, but it is growing. So I think if there's more demand for it in the pediatric oncology population, then when those centers deem, okay, we have some additional funding, we're going to hire a drug access navigator specifically for that population to help with them accessing various programs. But it is sort of still at the, it's something in the future at this point still. But it doesn't hurt if you have questions to still just email them to at ODANO. I would just tell you that same thing, but it depends on the question. If there is someone that we know about or we can connect you with, we would do that. But when it comes to specialty populations or other disease areas like cord and rare disease, it's something that I feel is coming up in the future.
Great, thank you. Our next question here, do drug access navigators refer patients to respective patient organizations for patients or caregivers to get psychosocial support and other informational resources?
So that's kind of I guess it's like a gray area. It depends on the center and the drug access navigator. So some drug access navigators are pharmacy technicians. Some of them are pharmacists. Some of them are social workers. So you may see that if you go to a center where your drug access navigator by background is a social worker or a nurse, and they're familiar with the different patient support programs, the patient groups, they may refer you to those. They may, depending on the center, it may be left up to the physician to do that. It may be something that strictly comes from the social worker. It really varies from hospital to hospital, at least in Ontario. But we do have links on our ODANO.ca website to a bunch of the different patient groups. So we do hope that if there's somebody who's newly diagnosed or is looking online, that they do find our website and can see that I have mesothelioma or I have lung cancer, and they can go to those patient groups from our links, and vice versa, that if they go to the Lung Cancer Canada or something like that, that there will be a link to ODANO from there as well, and that we can cross-support each other. And if they find us first, they can find the patient groups from ODANO as opposed to from the center.
Great, thank you. Next question here, how is ODANO funded?
So we're actually all hospital employees. So one of the criteria for joining ODANO is that you are working in the public sector. So everyone who's part of ODANO is, like I said, they're either a nurse or a social worker. I work at North York General Hospital, so I'm paid for by the hospital, and I'm a public employee. So all of us that are part of the ODANO group and any of the drug access navigators in the various provinces are all, they're like a social worker or a nurse. They're just another part of the treatment team.
Perfect, thank you. And that's actually the end of our questions. So thank you everybody who asked a question today.